everybody. This is Judy Thompson with Ava, and I want to welcome you to the I Save That podcast. We are going to try something different this time and offer CE for listening to this podcast. You have to listen to us for a full hour, but afterwards, we're going to send you to the website, fill out a survey, get a CE for driving in your car and listening, and hopefully learn a little bit. Before we get too far into this, though, I want to let you know that we are very grateful to EloQuest Healthcare. They are the sponsors of today's podcast. A premier AVA sponsor, EloQuest delivers solutions to overcome common vascular access challenges and is dedicated to advancing clinical education. Together, our brands support your delivery of safer, more efficient care. Learn more at eloquesthealthcare.com. As I mentioned before, this is a CE program, and being such, I do need to give you or let you know what the learning objectives are. First, we want to understand discrepancies in practice between vascular access specialists and some of our physician champions. Also, describing some variations in training for central line insertion. And we will summarize some steps to improve multidisciplinary practice. A couple other details on this. First of all, afterwards, you're going to have to go to the AVA website, which I'll give you the information after the 50-minute mark, and fill out a survey to claim your CE. The bios of our speakers will be available on the AVA website under our podcast. And as far as disclosures, Dr. LeDunn and Dennis Wu are both consultants for EloQuest. Dennis also cites Covalon, Nexus, and Cathade. Dr. Freelander has nothing to disclose. Last but not least, we do have to discuss implicit bias. Just be aware of your biases, both conscious and unconscious, and give everything a fair shot. Thanks so much. Okay, let's get into it. Today, we have a great lineup. Dr. Jack LeDunn, who we all know and love, the vascular guy, Dennis Wu, and then new to our podcast, Dr. Adam Freelander. Dr. Adam is a pulmonary critical care doc, has a lot of credentials behind it. We're going to get into those in a little bit, but Jack, let's kick it off. We're talking about, are there two standards? And we're talking about vascular access, obviously, because that's all we ever talk about. So let's get into the subject a little bit.
Yeah. I'd say definitely there are two standards. The people in vascular access read a certain literature, they're well versed, they do a lot of procedures, get a lot of reps in their procedures. On the other hand, we have certain physicians, and I'll let you know, and of course, when you make generalities like this, you could certainly get it wrong, but the other physicians would be emergency department, critical care, and anesthesia. And they use vascular access as part of their practice. But unlike, say, the vascular access community, which is really all that we do, that there's a little bit of a different focus on the work. And I would say that I came up in the system. In other words, I came up, as a surgical resident, and the only thing I ever heard about was pneumothorax. We never heard about infection. I mean, before 2008, Medicare paid for all those things, and you didn't hear about it. And if somebody had an arterial injury, there'd be an M&M conference about it, perhaps. But, the only thing we really heard was to, avoid pneumothorax, and we knew how to treat it, with chest tubes or observation, that sort of thing. So then pneumothorax became, this big boogeyman. And you get into, what's your philosophy of practice? And it's really this. And some people, their philosophy of practice is to avoid pneumothorax at all costs. And I'd just like to ask Adam if this jives with his training, because he trained after I did. But can you speak to, say, fear of pneumothorax?
Yeah, no, I appreciate that. I think though kind of my training was, I'll say, for the next generation, and then we have the next generation that we're training with things. So there is evolution. fear of pneumothorax, and I'll share a personal anecdote with that. I think was a predominant driving factor in training. My personal anecdote, having kind of trained as internal medicine resident in a large academic facility, then stayed on as a hospitalist, and then came back as a pulmonary critical care fellow. I think because of that subconscious fear of pneumothorax, I wasn't comfortable putting in subclavian central venous catheters, which remain my preferred approach, not just because Dr. Ladon's become one of my mentors, not just because it's the safest in the literature, all those things above. But going back to my fellowship, is coming out of residency, is I was not comfortable putting in a chest tube. And in my own somewhat twisted rationale, because it actually logically doesn't make sense, but this is what goes on in the real world, is I did not want to expose a patient to a small but a measurable complication, i.e. pneumothorax, if I didn't know how to handle it myself, so to speak. That sounds great. I say that the logic makes sense, but also across medicine, that philosophy doesn't make sense in general. I'm not a surgeon, but I work with a lot of surgeons. It's not uncommon for a gastroenterologist to call in a general surgeon to help them with something, or a general surgeon to call in a vascular surgeon. So that logic didn't make any sense, but I think because I grew up at a time where we were kind of trained to be able to deal with our own complications until I was comfortable as a fellow to put it in a chest tube. I was not fully comfortable putting in subclavian central venous catheter. Yeah, I think the flip side of that is I had done so many IJs during residency, that's what I was comfortable with. So you get comfortable with what you're comfortable with. And so I had to kind of break myself out of that comfort zone to elevate my own personal training by becoming comfortable putting in chest tubes and then putting in subclavian central venous catheters. I think our approach these days with our learners, again, learners extend from interns in medicine all the way up through fellows and junior attendings and beyond, and our advanced practice providers and everybody else, is to go away from that mentality. And just because you can't necessarily deal with a complication you may cause doesn't mean it's not the best approach for the patient. So subclavian central venous catheters remain the best, and we have people around you that can help you out if you get into trouble, if that makes sense.
So of course, when you use ultrasound, we're puncturing the axillary vein.
Yes.
Just
Yes.
it's my thing. It's my thing. I have to go to. So then we get to like philosophy of practice. So there are certain philosophies of practice that I've come across over the years. So these things are rarely spoken about and never written about. So philosophies of practice, I saw Dr. Faisal Masood put it, we have to make it easy to do the right thing and hard to do the wrong thing. I find that's a really good philosophy of practice. Pittarudi says we have to do what's right for the patient and not what's convenient for us. But an alternative philosophy of practice is we have to avoid pneumothorax at all costs. And what happens if that's your philosophy of practice? So what happens is people will not do the chest site, the axillary vein. They won't do that. They'll use the jugular vein exclusively, and they'll go high in the neck because they're getting away from the lung. But the downside of the high in the neck is that it leads to a poor place for the dressing, and dressing disruption is frequent when the dressing is up by the mandible, the hairline, or the ear. And there are, papers in common sense that tells us that disrupted dressings is not good, in terms of, say, CLABSI or bloodstream infection. So it's a little bit of a reach, but, you just have to look at the pictures, and we've all seen, the photos of these, poorly inserted lines. And you just I just want the physician and the nurse to go to the foot of the bed and say, like, is that a proper insertion? Is that an optimal insertion? And if it's not, then we have to, kind of break the cycle.
Agreed. Dennis, I want to bring you in. So I know Jack and Adam are talking about the fear of pneumo. And when Jack and I were talking about this topic, fear of pneumo never, it wasn't something I was afraid of when I was learning central access. What about you? I mean, we were learning on the tiniest vein in the arms, and with ultrasound we could get them at, 99.9% of the time on one go. And then you put an ultrasound in an IJ, is like, geez, this thing's a channel comparatively. Tell me your thoughts.
I thought the same thing. And when I actually went to the thoracic insertion, I couldn't wrap my head around the orientation because I was so calibrated to the arm. And I actually had a hard time visualizing and interpreting what I was looking at in regards to the needle to the anatomy. So I actually had a really hard time transitioning from pick to IJ. And yeah, the target is huge, but you have to know the orientation of where your probe and your beam is relative to your needle and then relative to the anatomy. And I struggled with that at the beginning. Like I got my first IJ in beautifully, no problems. But then the next two or three, when I was in Illinois, I had to have the preceptor come in and finish out the needling because I was having a hard time visualizing. And I didn't want to BS and say, oh, I think it's there, but I don't want to look bad, so I'm just going to keep going. Wasn't willing to risk that. And so I bowed out and said, hey, I'm having a really hard time finding this needle tip. I'm going to have you come in and finish this out. And so, yeah, it's not an easy shift if you disrespect it. If you're like, it's a big target, whatever. I'm so
Yeah.
good with ultrasound, I can hit any target as well. That'll get you into a lot of trouble because that's how I walked into it. And that first hit definitely got me very confident, but then the next two or three, but then after that, after practicing some more and putting some time with the mannequins helped a lot.
Great.
It was just a calibration thing, and all I needed to do was put some reps into just getting used to where the head was, where the IJ's going, and my orientation with the probe, with the screen, all of that. After I got
Yeah,
some reps in, I definitely got a lot better. Yeah, one thing that I definitely don't do and avoid at all cost is BSing my needle. Like that'll get you into so much trouble.
What do you
And
mean? BSing your needle?
you have to be very confident where your needle tip is.
Oh God, yeah. Yeah.
And if you're at the shaft and you think you're at the tip,
You're in
you're going to
trouble.
perf through a lot of things.
Yeah.
And so that's something that I highly feared and respected. And so I think that's something that needs to be very, very carefully approached by beginner inserters. It's like don't try to look good in front of your preceptor. Try to do the right thing for the patient. If you don't know where it is, you got to admit it.
Yeah.
All right.
I
So
think
let me jump in. Let me just stay with the pneumothorax thing. Dr. Friedlander, what do you think? What do you think the fear of pneumothorax is related to? I don't know if I can give you more information on it, but what do you think? Like, why are they so scared? Like, what's
Yeah. Well, yeah, no, it's a great question. You don't have to give me more information because I've been paying attention to you in a very good way, in a very positive way over the last what 6, 7 years now. Is that it's directly traceable back to the inserter.
yeah?
That's the fear. Well, I think I think that's the major fear. I think there is a fear of inducing patient harm, which obviously we want to avoid that. So there's the patient harm and safety. But the reality is pneumothorax is easily correctable in a patient if it is induced iatrogenically. But the fear is the iatrogenesis of the complication is the fear.
So, so Adam just brought up a couple of important points. No, number one, pneumothorax can be avoided. There's a technical solution to avoiding pneumothorax, and Dennis elucidated that, namely the ability to follow your needle will abrogate pneumothorax approaching 100%. If you can follow your needle through the tissue, that is a technical solution to preventing pneumothorax. Then there's a technical solution to treating pneumothorax. Namely, you insert a chest tube where you can observe them. It really comes down into those two things. But like there's what I mean by a technical treatment, it's in our hands. We can prevent it and we can treat it. Untrue for bloodstream infection. There is no technical prevention, and there's really no technical treatment for bloodstream. It's a process. In other words, you have to do everything right every day. That nurse invades that line in ICU 25 times a day. You've got to give the right, you got to go through all the care and maintenance steps to avoid an infection. But the pneumothorax thing is got a technical prevention and a technical treatment to it. And I always say, like, to the guys that are scared of it, I always say to them, do you know how to put in a chest tube? And more the critical care guys and the ER guys know how to put in chest tubes. And I'm thinking, like, we're approaching irrationality. But now, carrying this theme forward, what happens if you're trained by somebody whose philosophy is to avoid pneumothorax at all costs? Like, you have to realize that people are doomed to do this procedure the way they're trained, unless they go out and get other, reach out like we all did, and got some other viewpoint, some other training. You're doomed to do this procedure the way you get it in training, unless, something big comes out. So now you're being trained by somebody that's fearful of pneumothorax. And like, suppose you finish your critical care, then you go on and become the director of the ICU. You go on and become the chief medical officer, and you're training people to be scared of pneumothorax. And if you think about this, like going back, it's in there 50 years. Like, and I was discussing this with one of the executives, and she said, "Oh, we need more data." I'm saying, no, you're missing the point. This is fear. This is fear. This is like, hey, mom, there's a monster under my bed named pneumothorax. Like, this is not like it's in the literature. You can find this literature support for doing axillary subclavian venipuncture. I mean, it's been there for decades, that kind of a thing. But people won't do it because they're trained by people that were, scared of pneumothorax. Now, I have a small psychology practice, and I deal with this kind of stuff all the time. And I've been unable to solve the issue. So then you get into, because of the fear of pneumothorax, what are people doing with this? They're putting the insertion high in the neck. So high in the neck is a passive mechanism to avoid puncturing the lung. The further you are away from, you can still do it. Don't get me wrong, you can still puncture the lung. But the further you are away from the lung, the less the chance of hitting the lung. But that leads to the crummy dressing, the dressing in a bad spot, which, so I'm trying to get like dressing well as a metric. We all kind of agree that dressing's supposed to stay on for 7 days. And then you ask, how long are they staying on? They're not certainly not staying on for 7 days, So then the big question to me is, what can we do to prevent pneumothorax and to minimize dressing disruption?
Well, no, these are, Dr. Lund and I, as always, these are excellent points. Not to pivot to something similar that, again, you said a lot there, all very good as usual, and insightful. But going back to, one of the challenges, we have across all of healthcare with this is exactly what you said, is that you practice as you learn. And if you're not willing, and I'm not giving myself or Dr. Ladon or Dennis credit, I'm giving all of us credit to have an open mind to alter our practice. but going back, I'll get something specific. Is yeah, you learn how you train. So I was trained. I shared a little bit about my again using your words, Dr. Ladon. I was approaching irrationality. My logic, my internal logic for not being comfortable putting in a subclavian. And to all of your points is that when I during my training, which wasn't that long ago, I trained in residency fellowship in the early 2000s, early to mid 2000s. So that's relative. That still was within the last 20 plus years. Is to Dr. Ladon's point, is although a mid-axillary approach, ultrasound guided mixed approach was in the literature, that was not something that was being taught. And I can't blame anybody. I can't blame my mentors. I could, but my mentors didn't know that, and it wasn't until I connected with Dr. Ladon and his team that that's something that I learned. Same thing, very similarly. So I was, not me, but a generation of me's, right? Internal medicine residents, pulmonary critical care fellows, and and multiply that over the generations across the country were trained to do an IJ, mid IJ, mid or above, is as close to the ear as possible without hitting the ear, so to speak, to avoid an pneumothorax. And also, we were taught you always nick the skin. That was not. If you look at, I still have my old checklists of from when I was a resident, when they would sign off on us of being checked off by your senior resident, your fellow, or your attending doing central line. Nicking the skin was a non-negotiable, right? That didn't say optional. Nick the skin as the next step after you insert the wire. I don't want to give Dr. Ladon too much credit. He in a good way. He deserves all the credit. But it wasn't until I connected with him where my philosophy changed in terms of that, is that we could put central lines in without nicking the skin. And yes, to quote him, skin is the barrier to infection, and it doesn't make any sense. But think about I don't want to say hundreds of years, but 100 years, right, of several generations of inserters, which spans from critical care medicine, ER, anesthesia, surgical critical care, trauma surgery, IR. Were taught and ingrained on them that the next thing you do after you insert a wire is to nick the skin, and that's a hard thing to unlearn, because I'm going around and trying to unlearn it person by person is almost the only way you can unlearn that type of behavior that's so ingrained into what you've been doing for 5, 10, 15, 20, 25 years in some people.
Great point. Last time we did a webinar, I had hijacked the webinar that Christy Gaskell was doing, and somebody sent me a quote. I meant to. I'll put it when we do this presentation. I'll put in there. They said that she put in all caps, "Changing hurts the soul of some people." Like, that's how deep it is. And let me just go. So let me go into cutting the skin. Came up, and like, I have these 16 recommendations, and cutting the skin is one of them. And sometimes people focus on not cutting the skin. Jamie Bowen Santa Lucido, who I think the world of, told me once, every time she doesn't cut the skin, she thinks of me. I'm going, thank you, Jamie. So how did I was trained in nicking the skin. You know what I mean? And we used to have these Johns Hopkins critical care fellows wrote Moonlight at GBMC. So one night we were at like a code situation. I think he was put in a femoral line, and he just dilated it up without cutting the skin. And the light bulb saying, well, how holy, you know what I mean? It just takes that one somebody to examine the practice, and that was it. Then I said, let me start doing this thing. And there's some techniques. One of the techniques to learn how to do it is I teach people, like, you have to kind of, like, you got the wire in and now you're dilating. My finger's the dilator. You don't start working it at the skin. You push it in till it resists, and then you start working it to, you know what I mean, if you're having difficulty with nicking the skin. But that's a good example. I consider it a minor point of the 16.
No, my God, it is a minor point, but I think it's incredibly important. And just thinking it's become almost the hardest behavior. It seems minor, and I'll give you a specific example. for learners to overcome. So when I'm working with, residents and fellows and advanced practice providers who, who have been doing this, for a variable number of years, learn from and working with other junior attendings, they, kind of walking them through, they get low IJ approach, not taping it to the earlobe, all that's an easy sell. You say, why didn't they do that beforehand? Well, they didn't, same thing. It goes back to not that there's two standards, there's multiple standards because you learn how you were taught. That's the challenge, both individually and as a system. But it's easy to show them, okay, we're going to do a low IJ approach, start introducing the concept of cannulating the axillary vein. Those are easy sells. When you get to nicking the skin, that's where you induce an existential crisis in the learner until you get, because again, it's ingrained in them, right? They say it's still on our checklist, and some of our checklists out there, it's still there. And so that's often a big, a barrier, bigger barrier than you would predict to overcome. Because they just never done that before.
Do you find the same barriers with suturing?
That's short answer, yes. There's a much longer answer to that. Well, it's good. I think yes. The difference is, and this may get to not the overall theme, but is vascular access in the real world is the challenges of the devices that we have for sutureless lung securement. And as you know, there's a number of devices, number of things. Just you can't get them everywhere. And I know that goes on one hand. Again, on one hand you could say, well, that's somewhat of a cop out. And the other hand, and once again, in a very positive way, to quote Dr. Ladon, one of the challenges is that when supply chain is in charge of vascular access, if nobody else is, that's a challenge. And so I think it's an easy sell. So the logic behind, and even without the literature, but you saw in the literature of sutureless securement devices are better than nicking the skin. Everyone said it makes perfect sense. Where you hit a wall is, okay, well, what can I use? The stat locks may not be easily accessible. They're sometimes not ideal. We have larger catheters. What do we do with? I'm throwing a lot out there. This is what goes on, not just within a healthcare system, but each healthcare system has its own hospital, and we're trying to line things across all the hospitals, and they all have different equipment. And so what also with the learners I've learned is that they say, okay, give me something that works. And that's a key thing. Give me something that works. And as soon as you give them something that doesn't work, not that the device doesn't work, but a great example is dialysis catheters. Our healthcare organization, as attuned as we are to this, still hasn't come up with a device solution for our larger bore central venous catheters to avoid suturing. So the sell isn't not to suture. It's okay. Give me something that I don't have to. And then that also goes back to the theme we're doing is vascular access in the real world that's readily accessible. Is it in our line carts? We have line carts now in all of our ICUs, but we don't have all these devices. Do I have to stop what I'm doing in the middle of the procedure and ask a nurse to run down to supply chain? You say, well, that sounds ridiculous. It happens every single day. This is the real world. And so if you do that, it's going to be real hard to get somebody to embrace something that is better if you don't have the right tools for them.
So a lot of points.
Yeah.
Somebody has to be in charge of the cart. Somebody has to be in charge of vascular access, or you get behind. So one question: is there any society that recommends suturing? Judy, is there any?
No.
All right. So now let me bring in. What about the manufacturers that put suturing in the kits? They know better. The manufacturers know better, and they'll cop out. Oh, the market isn't ready for it. Like at a certain point, like we designed our kit without suture. So in other words, if you wanted to use a suture, you had to ask for the suture. There was a securement device in the kit, you know what I mean? But I think the manufacturers have to they have to step in. They're the ones putting sutures in there, and they know better. So it angers me.
Jack, there's still companies that put staples
Oh
in.
yeah. Oh. Come on, just shoot me now. You know what I mean? Like staples are not for the benefit of the patient. Staples are for anesthesiologists and ER doctors that are looking to get this thing in and get out of there and save zero point 0.6 seconds out of their life. I mean, like staples are not for the benefit.
True, true.
I've got a couple of staple pictures that I'll show our
Just
presentation. But,
couple.
but I did bring up, I think the crux of this, and Adam took it his way, and I always learn something, from Adam. So how can we prevent pneumothorax and minimize dressing disruption? That's like, in other words, if people can get this, uh, you know, at least it's a philosophical framework to move forward. So that's the question. Like, yes, buddy, you avoided the pneumothorax, but now you've got a dressing by the ear. So how can we prevent pneumothorax and minimize a crummy location for the dressing? Dennis said, I mean, like, Dennis said it. You learn to follow your needle through the tissue. If you can follow your needle through the tissue, you will not get pneumothorax approaching 100%. And if you can't follow your needle, you probably shouldn't be doing this procedure. You know what I mean? If you can follow your needle, you can put it as low on the neck as you want because you're following your needle. You know what I mean? That you're preventing a pneumothorax by following the needle and you're getting the dressing in the right location. So I think that's how I'm going to deal with this. But the psychopathy is not being dealt with, for sure. And until we deal with the psychopathy, we're not going to get any place. So again, Dr. Dunn's question is, why do doctors do this? They're scared of pneumothorax. And I mean, it's fear, it's irrational, you're getting into the it's not there's not a literature-based problem. It's a psychology-based problem. And, so in other words, as I teach somebody, or we have this webinar, 300 people learning the wrong way today. 300 people in this country are going to learn to put lines in the wrong way. It's like, it never's going to get extinguished. And now, I certainly haven't been able to solve this issue, but I'm on it. I'm on the case.
Hey, July 1st is coming up too, Jack. It's going to
Yeah,
be a lot more than that. But
yeah, yeah, for sure.
so I want to add one more thing to just the thought process. So you guys, Dr. Ledun, Dr. Freelander, you guys know how to do a lot. Being physicians, your breadth of scope of practice is enormous. Dennis and I, when we go in to place a line, it's like game on. This is the biggest thing we're going to go do. If I have and I had general surgeries, people that train me, and they have their option of going to do a thoracotomy or place in a line. My attitude was, come on, let's go. I have a line to place. And they're like, ah, shit, let's go place that line. I'm not saying this is equitable to all physicians, but it's almost like the same way that a lot of vascular access folks used to say, it's just a PIV. For a lot of physicians, it's just a line. For us, it's our career. What are your thoughts on that? It's a mindset.
I want people doing this procedure that thinks it's the most important thing they're doing.
Right.
At least at that moment, that this is, the most important thing that they do. I'd rather have RNs do the procedure than cardiac surgeons. For the exact point that you just brought up. Like, it doesn't rise to the level of importance in their life. And in a general discussion.
My comment on that, Judy, I think that you're getting the one of the part of the issues related to vascular access in the real world, again, using our theme, and not that what Dr. Ladon and Dennis is outlining is not the real world, but that's that's one of the challenges that you brought up. And I agree with Dr. Ladon is that in that moment in time, that inserter, be it critical care medicine, which I could speak the most about, but ER docs, anesthesia, IR, surgical critical care, whoever is the inserter is putting that line in. That needs to be the most important thing they're doing in that moment in time. But to your point, it is. But here's the practicalities of it. If I'm an intensivist at one of our satellite hospitals, again, our satellite hospitals are not small hospitals; they're just smaller than our main hospital, right? We have nearly 1,000-bed hospital. What we have, that's our everything hospital. So we have residents, fellows, level 1 trauma, all that. And then our satellite hospitals, ICU ranges in size from 4 ICU beds to 24. And that 24-bed ICU is a big, busy ICU. We only have one intensivist in each one of those ICUs. I don't want to make this a discussion about staffing. It's a discussion about the realities of what goes on in the what we'll call quote unquote real world. And in my real world is, I think, a microcosm of what goes on not just in the rest of the state, but in the rest of the country. But if our ICUs have single coverage intensivists in all of our units, which is more than adequate. But if there's a very, very sick patient comes in, it's you, and you, right? If the patient requires, it's not uncommon. This is what we do, not just taking care of the patient and everything going along with that, but all the procedures. They need to be intubated. Now you got to put an A-line in them if RT can't get it. Putting a central line in. A couple hours later, we're putting a dialysis catheter. Not that we cut corners at each one of those steps, but when it's just you doing all of those, not to bring things full circle, but it goes back is that you physically don't have the time. We always have the time to do the right thing, but if the micropuncture introducer kit, which is something we can talk about, isn't in the line cart, which is something that we're still working across our system, I don't have the time to stop what I'm doing, find the one person in the hospital who knows where that is. I happen to know where it is. It's down in IR because that's where they live. And so if I can get somebody to run down there and get that, or more likely I need to go and hunt and peck for it myself. It's no fault of anybody else's, just the nurse that I'm asking to do that doesn't know what I'm talking about. Not his or her fault. And so then I have to stop what I'm doing and go find the right equipment. That's a big barrier.
Now, so lean principles. You've identified this problem. It shouldn't happen recurrently.
Yeah.
You know what I mean? Like you solve the problem, like, hey, the micropuncture kits aren't available. You solve that problem, like baby steps. Like that should not be a recurrent theme. Let me switch to training in this, like a physician training, which is a big deal. So I have a big experience in training people, training institutions. I have a good experience with this. There are basically 3 elements to training people in central venous access. Okay, it's the didactic, simulation, then hands-on proctoring. So my finding from just like general observation is the didactic, I'm not sure what they'll get sometimes a computerized, like a system like MedStar in Baltimore, where I wound up, had a computerized learning module, and it wasn't bad, but again, it's out of date with the ear, dressings by the ear thing is not addressed, right? Then hospitals will have a simulation course, which is good, except they're not teaching the modern ways to do the procedure. And the third aspect, hands-on proctoring, like for example, I was in a 650-bed hospital for 3 months 2 years ago. And the assistant director of intensive care told me multiple times that he was not able to teach people to do central venous access, like scrub in with them. He did not have the bandwidth, the time. That's not what they had. So apparently, the resident that was learning the procedure got trained by the resident that learned last month. So, we all recognize this as a bad method for training, like that shortcuts and bad habits are going to be introduced. Then troubleshooting. I mean, like again, you're doomed to practice by like the level of the skill of the person that trained you. You know what I mean? How much troubleshooting can you do? Like, so I was, famous hospital in California in the Bay Area. They had a piece of paper that if you have done 5 of these procedures, you were signed off. At MedStar, it was 2. If you did 2 procedures, you were signed off. So like in the literature, and there's a paper, and some of our friends are on it. Peter Rudy Dawson, Nancy Moreau, Tim Spencer's on it. I think Brescia is the author, but don't quote me on that. And in their paper, they said that their number was 50 proctored hands-on insertions. And like I would say, as a trainer, my number was 50 for generally. If you were to ask me to pick a number of how many procedures I would have to proctor somebody to learn the low jugular approach, and I come from the side of the bed, and the axillary vein approach, I would say the number is 50. Now, we had and we were teaching, the advanced practice PAs and nurses. And I remember one of them, we went to 100 and we're ready to give up on her when she got it. You know what I mean? So the number is fluid for sure. And let me say one other thing about the number. When I was training people, we had to train them how to use the ultrasound, how to become familiar with the ultrasound. Now, when I get people, they really know the ultrasound. So maybe the 50 could be a little less because they have ultrasound knowledge and skill before they get to me. But it's not 2 procedures, it's not 5. And if the attending staff is unable, to coach somebody through this procedure, to me, it's a big red flag. It's a big red flag that these people likely never become, and my level of competency is that I could be home in bed and that person was going to do the right thing or call me if they ran into trouble. But that was the standard that I was looking for. That person that I would be comfortable, that person would do the right thing, or they would call, hopefully before they got into trouble.
Can you share the story about that one seminar where they freaked out from that number? And I think it's important because I think it's the sentiment across our culture right now.
So I'm going into the 50, and it's this hospital where I was wound up being there for 3 months, and like they latched onto the 50 and they started doing the math. Like we got, first of all, they wanted me to train 200 physicians. So my son said, "Dad, how many lines is number 197 put in per year?" But anyway, so we started doing the math. Dr. Dunn wants 50 proctored insertions. We've got X number of people. Like this is like, like a million lines. Like it was impractical. And they kept coming at me, and I kept going, yeah, it's 50. Well, so, it's 50. And at the end of the conference, Dennis says to me, "So you say the number's 50?" Yeah, like they kept coming. They kept trying to sneak up on me is that what you're referring to, Dennis, or?
Yeah, it was funny because you went on with the rest of the presentation, but they kept saying, "Hey, so you're saying 50 insertions or 50 practice?" Like it was multiple times throughout the rest of the presentation. They kept coming back to that number of 50 because it was so outrageous to them that 50 was a competent, like a decent competent number. And I think it's because it's so far off from what they're used to the 2, the 3, the 4, and they're just like, wait, 50? What are you talking about?
So it, comes down to competency, expertise. You know what I mean? Like there are different hurdles that you get over. As you know, Judy, in your own practice, you get over this hurdle, you get over this hurdle, pretty soon you're fairly expert. Like to troubleshoot, like the vascular access nurses, they're great troubleshooters because they troubleshoot all the time. It's a great skill. But so train, so a couple things. Their philosophy of practice is off if it's pneumothorax at all cost. The training is deficient.
Isn't
We're
there a saying
starting to
for that?
see. What's that?
Isn't there a saying for that? See
Uh,
one, do one, teach one. It's something that we
yeah,
pride ourselves
yeah,
in
yeah.
saying.
No, it's see one, do one, write the paper. You know, uh, it's like we need a reorientation, and sometimes I feel that institutions they don't want to really fix CLABSI. They want to talk about fixing CLABSI. You know what I mean? It's easy to talk about like so the things we're talking about, they're easy for us to talk about and they're hard to implement. In other words, if this critical care department doesn't have the bandwidth for their attending staff to be proctoring the trainees, number one, like they've lost sight of the ball. You know what I mean? They've lost like that's their job. That is their job to train people. How they do it, we can discuss that. I mean, I did graduate it. I mean, I would be with the people, scrubbed in, and then I would move to the, foot of the bed and watch them, and then I'd be outside of the nurses. I would give them graduated responsibility. You know what I mean? But if the attending staff is saying they're unable to train the trainees, there's a problem.
Have you found any? I mean, this has been a little bit since I practiced. It's been a couple of years since I've worked at Ava. And I still had some physicians that said, I'm great at the blind stick. I'm sticking with it. And they would not learn ultrasound. Are you seeing any of that anymore in the country?
Yes,
Oh, good.
yes.
Wow.
Like,
Reflecting back about thinking about practice, and I've never placed a central line without ever. I learned how to make blind or place blind picks way back, but since was placing central lines, never placed one without. And I can't even fathom the thought of jabbing around a neck in just hopes of missing a carotid and hitting an IJ. I, it's
if Simon Astor was on, um, we we had we had an event. We went to the operating room, and anesthesia was going to let us, do a couple. We had to get cases. I was there. I was with Simon for a week. And, we had to get cases, and I was showing him the axillary vein approach, and then different. I'm trying to get a lot of the things in, and he hit the vein. He passed the wire. Then we wound up losing access, and it was pre-op. They were trying to get a case started. And then the anesthesiologist grabbed the needle, kind of elbowed Simon out of the way, and started jabbing at the jugular vein without ultrasound. And then his colleague came in and said, "No, no, 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 man, you got to grab the ultrasound." It was there, it was sterile. You know what I mean? But they were just getting so flummoxed by, the case being delayed.
okay.
You know what I mean? But it's no excuse.
Right.
It's no
I
excuse.
Right. I think I told you this story way back when ages ago, you did a presentation, you were showing the respiratory variations on the screen. And I think you called them 1 and 2. And shortly after that, I went in and I had a patient that renal disease, had to go to her neck. She was sucking air. She couldn't lay flat. Everything that you'd worry about placing a line. And I threw an ultrasound on her and I looked at it, and she had both respiratory variation 1 and 2, sitting up, semi-Fowler in a bed.
So that means it's swinging back and forth and opening and closing.
Oh, sorry. Thank you.
Yeah.
Thank you. And so I called in the surgeon that ordered the line, and I said, "Hey, take a look at this." And he goes, and I said, "This is pretty complicated. Do you want to do it?" And he goes, "Oh God, no. That's why I don't use ultrasound. That's scary." And I
Yeah.
went,
Yeah.
I mean, the line went great. Everything went great, fortunately, but it was sometimes seeing what you're seeing is scary too.
But it was your experience that got, like with, in the arm, in the pics, it's all the experience that you brought to the procedure that enabled you to go forward.
Well,
Probably.
so they preferred to try to attack that moving target blind
Well, he
because
preferred
they
to not
couldn't.
know it was there, Dennis.
Right.
It's a
Let
see
me,
no evil, hear no evil, which it completely unacceptable, but I can empathize with.
yeah.
And I can answer is I think it's out there. I think at the bedside, I can speak from some experience with anesthesia and ER, but my critical care is it's been some time since I've come across an intensivist who has not embraced ultrasound. I'm not pitting us against anesthesia, but I've
Right.
witnessed, same thing. I've gone as part of my mentorship, gone into the OR. This goes back way back to when I first met Dr. Ladon with his encouragement to say, "Hey, just see what's going on." And witnessed to my horror, and the anesthesiologist was aware of anesthesiologists, with the ultrasound literally sitting next to them, putting in a blind, usually it's an introducer cordis, which is just a large central, for pre-op surgery. And the anesthesiologist turning to me and saying, I know I should be using ultrasound, but I've done this a bazillion times. And, in that I said, okay, fuming and exploding internally. And yes, that I didn't let it go. That led to a conversation with the head of anesthesia and hopefully corrective action and behavior on the part. But it goes on out there more than we think, I think.
So my rejoinder to the guys that have done this a bazillion times is like, yeah, I know you're great. What about the vein? There's two people in this dance. You know what I mean? Like if the vein's not suitable, it doesn't matter how good you are. So my anecdote, young child, developmental abnormalities, cardiac, um, died as a result of a blind attempt in a famous hospital. The famous hospital made a rule, and it was way past. It wasn't the old days. I mean, it was like within the last 7, 8 years, and the hospital made a rule: you have to use ultrasound. The guy that did it said, "No, I'm not. I'm not." Like even though they made it, so I don't know where it stands. If you're violating hospital policy, the guy that led to the demise of the young patient is now refusing the remediation of the hospital policy. So I don't like it's wafting its way through the courts with a date now in 2027 for whatever reason. But I mean, like that's the level that even if the hospital makes a policy, this guy says, "Well, I'm not going to adhere to the policy." I
Wow.
don't know how common that is. I'm sure the Russ Nassau's of that hospital are, unhappy with that position.
There's so many great things that we were highlighting that needs improvement, and it's because investigated, we've listened, we've been open-minded about these issues. For those who are listening, who are like, okay, this is great and all, but it's like Adam said, logistically it's almost impossible. There's so many little steps that we need to get to just to get sutureless securement device, just to get that one thing. There's so many steps that we need to get to, and it can be overwhelming to someone who's like, okay, I kind of see this as a problem and I care about it, but it looks and feels like such a big problem. I don't even know if I want to attack it. What will be the first one or two steps out of all these things that we've talked about that clinician can start tackling? And unfortunately, I don't think it's for the nurses to do because we don't have as much practice independence as physicians. So I think it's a question for physicians who are interested, which I've had a few people come up to me and say, "Hey, I'm anesthesiology. I'm in an intensivist at this hospital for like that Resus X conference. What would you say or advise them? Hey, this is the first one or two steps that you should take if you want to tackle this big issue called vascular access."
Are you talking equipment? Like, so I've tried to break this down into like philosophy of practice, techniques, and equipment.
I want to hear a little bit about both, Jack. Not just, yeah, we need a micro introducer kit. Yeah,
Like,
we need
like,
sutureless securement.
right.
Yeah, we need
Right.
probe covers, but
Yes.
more
Like,
so a physician champion in my book. To be able to push this practice.
yeah. Yeah. No, I think that to get physicians to change anything, I think it's better to come physician to physician,
Yeah.
just for the hierarchical, not that it's right. Now, I certainly learned, you know, my mother was a nurse, my sisters are nurses. The
But
assistant to vascular access taught me a lot of things, Okay, so when I lecture, and I admit there's a lot of stuff in a 60-minute lecture, and so I'm trying to get the three things: the philosophy of practice, the technique, and the equipment. And a lot of times what I find is the people will focus on the equipment. So today we talked a lot about sutureless securement, and another one is the micropuncture equipment. And they're there, oh, well, like, oh, well, look at the fancy equipment you have. And I'm there, buddy, what do you think? I came down on December 25th and I found this under my tree. I saw this stuff was like, I saw this stuff was better and I got it implemented. I went through like later when I learned you had to go through channels, got the stuff, but you can do a low jugular dialysis catheter, temporary dialysis catheter with the equipment that's in the dialysis kit. You can do it with that. It's better, I believe, if you use micropuncture equipment. Those of us specialties, but like, then, oh, well, we don't have the micropuncture equipment. And that came up in today's conversation. But I think you have to get the philosophy that if I could change one thing, I'm going to challenge people to think of one thing. It would be to.
Jack, I'm so sorry, but I'm going to keep our listeners on the edge of their seat, listening for that one thing to hear a word from our sponsor. As we've reached the requirements for continuing education, dressing and dressing securement aren't just routine steps. They're critical to patient safety. EleQuest Healthcare offers solutions that improve vascular access device care and maintenance, making securement safer and stronger. Mastisol is the clinically proven gum mastic liquid adhesive trusted by clinicians to maximize dressing adherence and minimize the risk of infection. It's backed by best practice guidelines and published evidence demonstrating how improved dressing integrity supports better outcomes for patients and clinicians alike. When it comes to catheter securement, SecuriCath is designed to stabilize for the life of the line. This subcutaneous anchor securement system requires no sutures and no adhesives. It dramatically reduces the risk of dislodgement and significantly reduces the risk of device-related infection while also saving time during dressing changes. Together, Mastisol and SecuriCath provide an unparalleled vascular access device site protection. To learn more about how these solutions can support your team, visit elequesthealthcare.com. All right, now we're going to get back to Jack's one thing.
If I could change one thing, stop doing the upward directed IJ catheter. Like the catheter, if it's directed up, and let me specifically say acute hemodialysis catheters. I've never seen a dressing intact in acute hemodialysis catheter was directed upward. Not one time. And I use never. I use like the classic definition of never. Like it doesn't, not unlike the CMS definition of never, CLABSI is a never thing where it happened 250,000 times last year. Like that's a different never than I use. But I'm saying like if I could fix one thing, it would be the upward directed IJ catheter because it's fighting the dressing. If the catheter comes out the bottom of the dressing, gravity's working with you, not against you. So like that's the one thing that I would fix.
What about you, Dr. Freelander?
Uh, No, I don't want to just piggyback on that, but I agree that that's the number one. And not just with dialysis catheter, I still see too often, and too often is more than, I agree with the classical definition, never should mean never literally. And I could say, as the corporate director of critical care medicine throughout our healthcare organization, which now spans across 2 different states and 25 hospitals, so it's another challenge. We should be seeing never either a central line or a dialysis catheter in the IJ that's pointing up. Can I say that is that occurring now? I unfortunately no, because all the logistic, a lot of the logistic educational. I think the logistic barriers are more so than the educational at this point. People kind of know how to do the right thing. They just don't have the right equipment right now to do the right thing.
Okay, Dennis, what do you say? We're going around the circle.
Just from my and for the listeners here, I'm speaking very ignorantly, and I'm speaking just from my observations from very far away. I think the champion is probably one of the first things we need. Like Jack, you were the champion to start this vascular access improvement at your institution. Adam, the same thing. I don't think we would have seen as accelerated of improvements if you didn't open your mind to this thing. Oh, we can actually improve this problem. And you took on that responsibility and wanted to push it forward. We If it's going to move forward, equipment, philosophy, education, and training, someone needs to care enough to grind for it and deal with the politics for it. How we encourage and equip them, Ava, INS, go to your organizational conferences and get educated and networked like Jack and Adam did, getting together and collaborating on improving institutional practice. I think it starts there. Without a champion, nothing moves forward. And so, how do you get a champion?
No. How do
Still,
you
I'm still looking for that answer.
grow a champion? Well, that's a perfect segue into Ava SM this year. So Orlando is where our annual conference will be. And not only do we have a pre-conference where you can learn central line insertion, but we also have Doctors Ledun, Dr. Freelander, and Dr. Astor talking about, we'll have a presentation similar to this, but going into a lot more detail. So these are things you aren't going to want to miss. But sign up for the pre-con, learn the skills. This is not for the very beginner that's never used an ultrasound before, because you aren't going to learn the basics of ultrasound. But this is if you want to bring your practice up and learn how to follow your needle tip a little bit better. And if you want to learn how to place mid-thigh or tunnel a catheter, all the good things that we should know, that's the place to be. Gentlemen, thank you so much. You guys have been fantastic. I can't wait for your presentation at conference as well. It's going to be enlightening for sure.
Thank you, Judy.
Thank you, Judy.
Thanks.
Appreciated this. This was good.
This was fun. Thanks a
Yeah.
bunch. First of all, thank you guys for listening. Now comes the challenging part of getting your CE. If you are listening via a podcast, an audio podcast, then you need to go to avainfo.org/page/podcast public. So again, that's avainfo.org/page/podcast public. And then click on this podcast, and in the More button, it will have the link to get to the CE survey. If you can see this via video, then there's a QR code showing right now. And you just, typical with what we do with all our webinars, point your camera at it and then fill out the survey. Your CE will be right there. I know there will be a few questions. If you run into difficulties, email us at avaed@avainfo.org. avaed@avainfo.org. And we will be happy to help you. So I hope you enjoyed this podcast. We enjoyed creating it for you. And we'll see you in the next one. Bye, everybody.